Okay, so how do we treat the masseter, and to some extent, why do we treat it? So, I mean, we treat the masseter from an aesthetic perspective to give us a masseter which is smaller, kind of purposely causing atrophy of the muscle to give the slimming effect from the anterior view, most commonly in female patients. The masseter may also be injected in cases of temporomandibular joint dysfunction and bruxism, although those are a bit more complicated in terms of the etiology. They tend to be multifactorial, related to bite and different things, but we're going to focus on how we might approach treating the masseter from an aesthetic perspective. And in 2017, Peng et al., so Peter Peng is really someone who's been involved in research of treating the masseter with toxin for many years, and this paper really is, I suppose, a seminal piece in terms of our approach to treating the masseter for aesthetic indications. So it's really a case series of over 2,000 patients whose masseters were injected with toxin, looking at rates of complications and incidence. And the other really useful thing about this paper was how it gave us this kind of strategy to approach treatment of the masseter from an aesthetic perspective in order to reduce complications. So if we look at this, Peng et al. Described this kind of zone of safety in order to treat the masseter and reduce complication risk while giving adequate effect in terms of this sort of slimming or purposeful atrophy of the masseter. So if we look at this diagram, you can see basically where there's a line drawn from just below the earlobe heading down towards the oral commissure. Once you've done that, it's important to palpate the anterior border of the masseter, draw a line and kind of join both of those lines up. Then palpate the posterior border of the masseter and draw a line there. And then basically join the lines of the anterior border of the masseter and the posterior border just underneath, running along the mandible. And we've got this little square and this sort of zone in which we want to inject our toxin in terms of treating the masseter. So, and even again within that study, yes, this is where we're basically marking out the area of injection in order to reduce rates of complication and increase safety even further. Peng et al. Also describe this square that we've drawn out, that we basically reduce the margins throughout by 1 centimeter in order to keep away from the areas that we really don't want toxin to diffuse into or have an effect on inadvertently. So 1 centimeter throughout. I think this is particularly important in terms of the anterior border because we really don't want to have an effect on rhizorius, which in many patients may actually be adherent to the anterior surface of the masseter. So we really don't want to do that. And then so once we've got our 1 centimeter margins marked out, from that point we have 4 injections within our area where we're going to inject, and typically 4 to 5 units of toxin injected deep into the belly of the masseter in using 4 to 5 units of toxin per injection point. I hope you enjoyed this content. If you did, hit like, subscribe and share to see a bit more.